Hi everyone, I'm back and still on toxic shock syndrome, but today I'll be talking about toxic shock syndrome treatment and differential diagnosis. But before going into the details of that, kindly go over my first presentation so that you can grasp the entire concept when it comes to the differential diagnosis and treatment. Okay, let's go. The possible differential diagnosis could be Streptococcal TSS syndrome. Remember, my first presentation has given clearer cut definitions of methicillin-resistant Staphylococcus aureus or methicillin-sensitive Staphylococcus aureus. Now, another differential is Streptococcal TSS syndrome. And if that is the case, there will be pain before the onset of symptoms. And that's likely going to be secondary to the trauma or possible necrotizing fasciitis. The other differential is septic shock secondary to other pathogens entirely. Also, drug reaction is possible as differential when we have toxic epidermal necrolysis or Stevens-Johnson syndrome. Also, in children, this might be Kawasaki disease or meningococcal infection. It could be Rocky Mountain spotted fever or leptospirosis, where you will need to do serological tests that will come out to be negative. If this is in a region where dengue fever is possible, you need to rule that out. And of course, in another region where enteric fever with typhoid fever or paratyphoid fever could be possible, they must be ruled out. Now, on treatment. Treatment will involve checking the airway, getting any obstruction, secretion out, then checking the breathing, chest moving with respiration, respiratory rate, you count that, you percuss, you auscultate, and then you look for central or peripheral cyanosis and any obvious deformity of the chest region. As far as the cardiovascular system is concerned, because we're going to deal with shock here, what is the blood pressure telling us? What is the pulse rate, the heart rate? And what is the fluid in and out here? And we're going to auscultate the base of the lung to know whether there are crackles from pulmonary congestion. And, of course, the extremities, cold and climbing, because we're dealing with shock here. And immediately, our IV fluid should be on. Okay. Normal saline, 1 to 2 liters start. Then maintenance with 0.45% saline and D5 water. Vasopressors, if IV fluid is not solving the problem. And of course, we have to explore the wound. We'll give our antibiotics intravenously. If this is methicillin-resistant Staphylococcus aureus, we'll go for Vancomycin plus clindamycin with Tazocin. Tazocin is piperacillin, tazobactam combined. And if this is methicillin-sensitive Staphylococcus aureus, we just go for Oxacillin with clindamycin. You can also use linezolid and intravenous immunoglobulin. You can switch to per oral when the patient can take per oral and the individual is not vomiting. In case of methicillin susceptible or methicillin sensitive Staphylococcus aureus, you can use cevalexin and dicloxacillin. But you want to give per oral and the patient is having methicillin resistant Staphylococcus aureus, you can use linezolid with clindamycin, and vancomycin per oral is also applicable here. Prevention here is stop using tampon, okay? And if you are to use tampon, you use it only for a short period of time. Then you embark on proper hygiene and wound treatment. The prognosis is such that about 2% to 6% mortality is possible in menstrual and non-menstrual Tazocin syndrome respectively. Death is usually due to cardiovascular system complications, renal failure, and disseminated intravascular coagulopathy. And with that, I've come to the end of this presentation. Kindly subscribe to my channel so that you can get these publications immediately they are released. Thank you.